Hello and welcome to the presentation on Mania by Dr. Ignatius Cole. This cartoon here shows the case of mania and the typical thinking like women are crazy about me, I can do anything, I know how to win the lottery, I don't need sleep, I have the answer that will bring peace to the world. Now let's go and take a look inside mania. Is too much happiness a bad thing? And as Edna Farber quotes, perhaps too much of everything is as bad as a little. So mania falls under the criteria of bipolar affective disorder. A single manic episode can occur, but usually it will be followed by an episode of depression. Or if hypomania occurs, it will also be followed by depression. If mania alternates with depression, that is called bipolar 1. Or if hypomania alters with depression, that is called bipolar 2. So epidemiology, the lifetime risk of bipolar disorder is 1%. What are the risk factors of bipolar disorder? Genetic factors, childhood physical or sexual abuse, stressful life events will trigger mania, high level of expressed emotion in the family, structural brain imaging reveals lower hippocampal volumes and other changes, abnormalities of hypothalamo-pituitary adrenal axis. So this is the chart which shows happiness and sadness. So in euthymia or normal mood, happiness and sadness are usually limited within a certain bit of spectrum. In depression, the mood is very low. In mania, it is very high. In hypomania also, it is elevated more than normal. So this is the chart. What are the symptoms of mania? The symptoms of mania are a mood, which mood means it is subjective, the patient feels it, which is predominantly elevated, expansive, or irritable, and definitely abnormal for the individual concerned. The mood change must be prominent and sustained for at least a week, unless it is very severe enough to require hospital admission. And B is that at least three of the following 9 must be present. 4 of the following 9 if the mood is merely irritable instead of elevated, and this leads to a severe interference with personal functioning in daily living. So what are they? They are increased activity or physical restlessness, increased talkativeness, also called as pressure of speech, flight of ideas, or the subjective experience of thoughts racing. There is loss of normal social inhibitions, resulting in abnormal, inappropriate behavior, decreased need for sleep. The patient may sleep for 3 hours and feel totally rested, inflated self-esteem or grandiosity, distractibility or constant change in activity or plan, behavior which is foolhardy or reckless. Example, the person may engage in spending sprees, foolish enterprises, reckless driving. And number 9, marked sexual energy or sexual indiscretions. What are the medications for the treatment of mania? There are typical antipsychotic drugs, atypical antipsychotic drugs, lithium, carbamazepine, valproate, and benzodiazepines. Benzodiazepines are used as adjuncts to calm and stabilize the agitated and overactive patients. They are not used alone. So typical antipsychotics like clopramazine and haloperidol are effective, and it does not matter if the patient has psychotic features or not. But high dose is needed and extrapyramidal side effects occur. But the typical antipsychotics will not protect against depressive downswings that will follow the resolution of manic illness. Atypical antipsychotics will improve tolerability compared to typical antipsychotics. Trials support the use of aripiprazole, asenapine, olanzapine, quetiapine, and risperidone. To find more detail on antipsychotics, watch the presentation on schizophrenia. Another drug is lithium. Lithium is very effective in the acute treatment of mania. It is as effective as antipsychotic medication but has a slower onset. Antipsychotic medication may be preferable in highly active states. Prominent depressive symptoms, psychotic symptoms, and rapid cycling predict poorer response to lithium. The side effects of lithium are diarrhea, anorexia, vomiting, blurred vision, muscle weakness, drowsiness, sluggishness and coarse tremor, giddiness, ataxia, dysarthria, hypothyroidism, and diabetes insipidus. We should monitor and maintain the plasma level at 0.4 to 1 millimole per liter. After the using the therapy, we should continue it for 6 months, and severely ill patients may be on both a mood stabilizer and antipsychotic drug. Now, how to use these drugs? If the patient is taking antidepressant, then we should offer an antipsychotic agent regardless of whether the antidepressant is stopped or not. If the patient develops mania or hypomania and is not taking any antipsychotic or mood stabilizer, then we offer antipsychotic. But if the first antipsychotic is poorly tolerated at any dose or is ineffective, we offer alternative antipsychotic drug. And if the alternative antipsychotic is also not sufficiently effective at the maximum dose possible, then we'll add lithium. And if lithium is ineffective or not suitable because the person does not agree to blood monitoring, we'll add valproate. And if the person is already taking mood stabilizers such as lithium or valproate, then we should consider increasing the dose up to the maximum level depending on the clinical response. And if increasing the dose of lithium or valproate does not have any improvement, then we should add antipsychotic. Electroconvulsive therapy. Electroconvulsive therapy has been found to be more efficacious than medications in the treatment of acute mania. Psychotherapy can be done after the resolution of acute symptoms. Cognitive behavior therapy, family-focused approaches, interpersonal and social rhythm therapy, and group psychoeducation are involved. Thank you. The references has been Oxford Textbook of Psychiatry 7th edition, ICD-10, DSM-5, Kaplan and Sadok Synopsis of Psychiatry. Please subscribe to this channel.